Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be continuing our discussion of prostate cancer with a talk on systemic therapy for localized prostate cancer. My goal for this talk is to start by discussing some of the common drugs that we use for androgen deprivation therapy and how they work. And then get into the evidence behind why we add androgen deprivation therapy for various periods of time, depending on the risk stratification. The most important thing to understand for systemic therapy for prostate cancer is that prostate cancer is driven by androgens, okay? And it's mainly testosterone. Testosterone acts like fertilizer for prostate cancer, and the testosterone binding to receptors within the prostate is one of the signals that causes prostate cancer to grow. And so some very smart people wondered, well, if testosterone acts as fertilizer for the prostate cancer, will it help if we actually suppress the testosterone? Will that improve outcomes for patients? And it turns out, based on the evidence that we will review, that when we're treating with radiation, adding androgen deprivation therapy for low and favorable intermediate risk prostate cancers actually doesn't provide much benefit. And so we try to avoid it, right? Because suppressing testosterone has a lot of side effects for patients that patients don't like. And so, if it doesn't provide a benefit, we don't add it. However, for patients with unfavorable intermediate risk prostate cancer or higher, it turns out that adding some degree of androgen deprivation therapy actually does provide a benefit. It tends to decrease their risk of distant metastasis as well as mortality from prostate cancer. And so we do add it for patients with unfavorable intermediate risk disease or higher. For unfavorable intermediate risk disease, short-term duration of ADT is sufficient. So short-term ADT is somewhere between 4 to 6 months. For high risk or very high risk disease, these patients actually benefit from long-term androgen deprivation, so 18 to 24 months of ADT. And it turns out that for a select subgroup of very high risk patients or patients with node-positive disease, they benefit not only from long-term ADT, but also from the addition of a drug called abiraterone, which is almost like another layer of hormone therapy that we add. So as you can see, just as we talked about with local therapy for prostate cancer, our systemic therapy is also very much risk-driven. When we're treating with radiation, we don't add ADT for low or favorable intermediate risk. We add short-term ADT for unfavorable intermediate risk, and we add long-term ADT for high risk or very high risk disease. And then a subset of very high risk patients or node-positive patients will also benefit from the addition of abiraterone. Now, all of this is when we're treating with radiation as local therapy. These are sort of the considerations for addition of androgen deprivation therapy. When patients with prostate cancer go for surgery as their local treatment, we typically don't do surgery plus ADT off the bat. Some patients with surgery might have either a biochemical recurrence or their disease never really goes away completely. And then when we do post-operative radiation for those patients, we may or may not consider adding androgen deprivation therapy, but we typically don't do upfront surgery along with androgen deprivation therapy. So all of these considerations for short-term versus long-term ADT, they really apply to patients that are getting radiation as their local therapy. So no ADT for low or favorable intermediate risk, short-term ADT for unfavorable intermediate risk, long-term ADT for high risk or very high risk, and then we add abiraterone for certain very high-risk patients or node-positive patients. Now, I just want to take a moment to mention, early in their development, prostate cancers tend to need androgens to grow, and so that's why ADT helps. In the metastatic setting, some prostate cancers can continue to respond to androgen deprivation therapy. And when that is the case, they are said to be metastatic castrate-sensitive prostate cancer. So that means they are responding to castration. I think castration is a little bit of an unfortunate term. We're usually not actually castrating patients, but it's kind of considered a chemical castration. So we're giving them drugs to suppress their testosterone, or in other words, androgen deprivation therapy. And if patients are continuing to respond to that androgen deprivation therapy, then they are said to have metastatic castrate-sensitive disease. Sometimes when prostate cancer is metastatic, it can kind of become far too mutated and dedifferentiated. And at that point, it's no longer responding to ADT. So what we see is when we measure the testosterone, their testosterone levels are adequately suppressed. However, they continue to have progression of their disease, either clinical progression that we can see on their radiographic imaging, or biochemical progression, which we can document with their rising PSA levels. And so if their testosterone is adequately suppressed while they're on ADT, but they continue to have progression, either a rising PSA or clinical progression, then at that point, the metastatic disease is said to have become castrate resistant. I just want to make that distinction between castrate sensitive and castrate resistant because those are terms that you might hear, and they really apply to patients that have metastatic prostate cancer. We're going to have an entirely separate talk on metastatic prostate cancer, so I won't get too much into the details of that here. For now, I think what's important to realize is that testosterone acts like fertilizer for the prostate cancer, and certain patients, depending on their risk of localized prostate cancer, or if they're node positive, will benefit from a certain duration of androgen deprivation therapy. So short term for unfavorable intermediate risk, long term for high risk or very high risk, and then remember we add abiraterone to long term ADT for select very high risk patients or node positive patients. So when we say androgen deprivation therapy, or ADT, what do we actually mean by that? What are the drugs that we're using for androgen deprivation therapy? I've sort of put some of the drugs that we use to treat prostate cancer in this diagram, and I've tried to kind of point them out in the hypothalamic pituitary gonadal axis. So if you recall, the hypothalamus secretes things that act on the pituitary, and then the pituitary secretes things that act on organs like the adrenal glands and the testes, and that ultimately results in the secretion of testosterone. Testosterone and other androgens then go and bind androgen receptors in the prostate, and that is what leads to the signals that kind of cause proliferation of prostate cancer. So along this hypothalamic pituitary gonadal axis, there are a lot of different places that we can intervene to kind of prevent prostate cancer from growing. So let's start at the bottom and work our way up. So starting at the bottom, at the level of the prostate, we can directly inhibit the androgens from binding the androgen receptor by using an androgen receptor antagonist. So examples of androgen receptor antagonists are things like bicalutamide, which is a first-generation androgen receptor antagonist, and another example is enzalutamide, which is a second generation. There are other ones too, like darolutamide, for example. And so androgen receptor antagonist is one class of drugs to be familiar with. Moving up then, at the level of the adrenal glands, we can use abiraterone to inhibit the enzymes in the adrenal glands that lead to the production of testosterone. And one thing that we need to remember is that in the adrenal glands, there's a bunch of enzymes and there's a bunch of things that feed into those enzymes. If we block just one specific enzyme, so if we block the enzyme that leads to androgen production, then upstream of that, things get rerouted to other things. And other things that the adrenal gland secretes are mineralocorticoids that lead to hypertension. And so actually abiraterone has to be given with prednisone, because if we don't give it with prednisone, then we might actually see too much hypertension. Hypertension is definitely a side effect of abiraterone and prednisone, but if we don't give it with prednisone, then we're definitely going to see that. So we do need to give it prednisone so that it doesn't upregulate the enzymes that lead to the creation of mineralocorticoids. So I think it helps if you actually look at a diagram of the adrenal enzymes, which I don't have here. You'd have to Google that. But just remember, abiraterone has to be given with prednisone because of the enzymes in the adrenal glands. And then even more upstream of that, we have what are called LHRH receptor agonists. So remember that LHRH is secreted by the hypothalamus, and it causes the pituitary then to release LH, which acts on the testes. If we agonize LHRH, that means we are kind of promoting the pituitary to secrete LH, right? But actually what happens in the testes then is that we get too much androgen creation, which leads to a negative feedback loop that then shuts off that LHRH agonization. So that's how LHRH receptor agonists can actually be used as androgen deprivation, because they feed into a negative feedback loop that then shuts off further creation of testosterone. So LHRH receptor agonists in the modern era are actually what we use a lot of the times as androgen deprivation therapy. So these are things like leuprolide or goserelin. The one side effect is that initially when we first start giving the agonist, we can actually have a testosterone flare. And so sometimes we will give them along with bicalutamide in the first month or so to kind of suppress that testosterone flare. And then after the negative feedback loop has kicked in, we can take away the bicalutamide and keep these patients on the LHRH agonist. And then finally, we have LHRH receptor antagonists, such as relugolix. Now, relugolix is a newer generation drug. It's very beneficial because it doesn't have a testosterone flare. It actually works faster than the agonist because you're not waiting for that feedback loop to kick in. So it's kind of like a faster on as well as a faster off. It actually even tends to have less cardiotoxicity, but the downside of it is that it's very much more expensive and it's often not covered by insurers. So we have a lot of different options for androgen deprivation therapy for prostate cancer. I would say the mainstays in the modern era are kind of those LHRH agonists like leuprolide or goserelin. Some patients, especially if they have significant cardiac history, we might consider relugolix. Bicalutamide we often use when we're giving LHRH agonists, 2 weeks before we give it and 2 weeks after we start the LHRH, we'll often give bicalutamide just to kind of counteract that testosterone flare, and then we take it away. There are some older trials where bicalutamide was given throughout as androgen deprivation therapy, but the big side effect of it is that it causes gynecomastia. So again, we either have to do prophylactic radiation for male breast tissue to prevent that side effect, or a lot of times also because it's a daily pill, patients prefer to be on leuprolide. That's kind of like a monthly or every 3-month injection. So they don't have to remember to take a drug every day. And so I would say those are kind of the mainstays of treatment. Abiraterone and prednisone, as we already mentioned, we actually add as an additional layer of hormone therapy for patients with certain types of very high-risk prostate cancer or node-positive prostate cancer. And then second-generation androgen receptor antagonists like enzalutamide or even darolutamide are often used in the metastatic setting. And they're also being investigated for adding in place of abiraterone for certain high-risk patients. So here is a table just kind of summarizing these drugs and some of the salient aspects that we just talked about, including their mechanism, their indication, and their side effects. So the LHRH agonists like leuprolide and goserelin, these are given as an injection and they can be given every few months, so even every 6 months sometimes, and so they end up being very convenient for patients. And this is, I would say, the most common drug that we're using when we say ADT for prostate cancer is often these LHRH agonists. The side effects that we counsel patients about are symptoms that are, we kind of call it like a male menopause. So they can have hot flashes, they can have fatigue, they can have decreased libido, they can have erectile dysfunction while they're on ADT, to the point where, it's basically non-existent while they're on ADT. We also worry about bone loss and cardiac toxicity, and so these patients have to be followed very closely. So LHRH agonists, pretty much the most commonly used ADT when we're giving ADT for prostate cancer. Relugolix was studied in the HERO trial, and it was compared to the GnRH agonist, and it was found to have a faster onset and faster offset compared to the LHRH agonists. And, it has improved testosterone recovery as well. The best part about it is less cardiac toxicity. So when we have patients with significant cardiac history, we often try to get them on Relugolix rather than Leuprolide or Goserelin. The problem with Relugolix is that it can be very, very expensive for patients, like thousands of dollars a month, and it's often not covered by insurance. Also, it's a daily pill as opposed to the LHRH agonists, which are an injection every few months. Bicalutamide, we talked about, is an androgen receptor antagonist, although it has partial agonist activity. It's kind of a first generation androgen receptor antagonist. It's also a daily pill, and it can often be given initially with LHRH agonists to prevent that testosterone flare that we talked about. Big side effect of bicalutamide is the gynecomastia. Enzalutamide is a second generation. It's a pure androgen receptor antagonist. It's often used in the metastatic disease, similar to all these other drugs that can cause hot flashes, bone loss, cardiac toxicity. And then finally, abiraterone, which is given with prednisone, remember, because it blocks androgen synthesis in the adrenal glands. We give it with prednisone or prednisolone because it kind of mitigates the risk of hypertension, but it doesn't completely remove that side effect. So abiraterone is given for very high risk localized disease. So patients that have at least 2 of the following risk factors. So clinical T3 disease or worse, grade group 4 or 5 disease, and a PSA greater than 40. That's based on the STAMPEDE trial. It's also given for node positive disease, metastatic disease, and then remember the side effects are things like hypertension and elevated LFTs. Now that we understand some of the most common drugs that are used for ADT and kind of an overarching view of when we think about ADT, let's get into some of the evidence, starting with the rationale for using short-term ADT 4 to 6 months in patients with unfavorable intermediate risk disease. The first couple of trials that we'll talk about are an older generation of trials that were started in an era where we were not routinely using dose escalation for prostate cancer. And so this is a conventional era before the dose escalation studies. And a lot of these studies actually showed an improvement in the overall survival when we added short-term androgen deprivation therapy. But again, this was in an era that was pre-dose escalation. So RTOG 9408 took patients with predominantly low risk or intermediate risk prostate cancer, and they randomized them to 66.6 gray of conventionally fractionated radiation with or without 4 months of androgen deprivation therapy. And the ADT that they used was flutamide plus goserelin or Leuprolide. And what they found is that short-term ADT improved 10-year overall survival, case-specific survival, biochemical recurrence-free survival, distant metastasis, as well as pathologic tumor clearance. At 18 years, the overall survival lost its benefit, but the distant metastasis failure and the biochemical failure benefits still kind of persisted. And so the conclusion was that mortality is likely due to other causes by the time you get to 18 years out. In terms of toxicity with the hormone therapy, and remember they were using the LHRH or the GnRH agonists, the toxicities were increased hot flashes, sexual dysfunction, and grade 1 to 2 hepatic toxicity in the short term. And then in the long term, they continued to have slightly worse sexual function in the androgen deprivation group at 1 year and low rates of other toxicities. They went on to perform post-hoc subgroup analyses. And remember, post-hoc analyses, the trial is not powered for these subset analyses, so you always have to take them with a grain of salt. But what they found is that the biggest benefit of short-term androgen deprivation therapy was in the intermediate risk subgroup. So if you look at the disease-specific mortality based on the risk stratification, in the low-risk group, there was a very low distant disease-specific mortality, I should say, in both arms. So it was, just around 5% or less in both arms, justifying the omission of androgen deprivation therapy. For high-risk subgroups, they had greater than 10% risk of failure in both arms. And so for these patients, we likely need a longer duration of androgen deprivation therapy. But in the intermediate risk group, that's sort of the sweet spot where the failure rates kind of dropped from, 10 to 15% down to single digits. And so the intermediate risk group is really where they felt the addition of ADT was most beneficial for disease-specific mortality. And so based on RTOG 9408, this supports the use of radiation and short-term androgen deprivation therapy, 4 months of ADT for intermediate risk prostate cancer. And remember, it provided a distant disease-specific mortality, distant metastasis, case-specific survival, and biochemical failure-free survival benefit. And all of these factors translated to a 10-year overall survival benefit. Keep in mind that we see this overall survival benefit, but the trial used lower radiation doses than what we would use in the modern day. So remember, this is pre-dose escalation study. In the modern day, we learned that dose escalation helps for prostate cancer, but not only does dose escalation help, in the modern day, we actually use moderate hypofractionation, remember? So radiation regimens are totally different in the modern day, and this was a much older form of radiation. So conventionally fractionated, not dose escalated. Now, if you need a silly way to remember 9408, my little mnemonic is 9408 showed us that 4 months of ADT benefits intermediate risk. So intermediate, 9408. 4 months of ADT benefits intermediate risk patients, and tie that 8 and 9408 with intermediate risk. Remember though, we said that we typically will utilize short-term ADT for unfavorable intermediate risk patients, not favorable intermediate risk patients. So where does that come from? There was a secondary analysis of RTOG 9408 from first author Zumsteg et al., and they looked at patients that were specifically classified as intermediate risk, and they differentiated them based on favorable intermediate risk versus unfavorable intermediate risk. And what they found is that patients with unfavorable intermediate risk disease had a higher risk of distant metastasis, prostate cancer-specific mortality, and all-cause mortality overall. So with the addition of androgen deprivation therapy, unfavorable intermediate had an improvement in these outcomes, but the favorable intermediate patients did not. So if you look at the 15-year rates of distant metastasis, prostate cancer-specific mortality, and all-cause mortality in the table, you can see that the p-values for the favorable intermediate risk patients were not significantly different. Distant metastasis risk was 8% versus 5%. Prostate cancer-specific mortality was 9% versus 14%, not significantly different. And all-cause mortality was 60 to 62% in both arms. For unfavorable intermediate risk, though, the distant metastasis risk dropped from 24% with no ADT down to 10% with ADT. Prostate cancer-specific mortality went from 28% down to 12%, and there was about a 5% improved all-cause mortality as well, 71% versus 66%. And so this unplanned secondary analysis of 9408 suggests that the distant metastasis, prostate cancer-specific mortality, and all-cause mortality is really for unfavorable intermediate rather than favorable intermediate risk patients. There was another study out of Harvard by first author D'Amico et al. That looked at the same question of radiation alone versus radiation plus short-term ADT. And in this study, they used 6 months of androgen deprivation therapy. Again, this trial was in the pre-dose escalation era, so it was 70 gray of radiation with conventional fractionation, and they predominantly included patients with intermediate risk disease. So 75% of the patients in this trial were probably intermediate risk disease. They also found a survival benefit to the addition of 6 months of androgen deprivation therapy. So there was a 10% improvement in survival at 5 years. So 78% with RT alone versus 88% with androgen deprivation therapy at 5 years. And the 5-year freedom from salvage androgen deprivation therapy was 57% with radiation alone, up to 82% with androgen deprivation therapy. In terms of toxicities, they saw worse grade 1 to 2 gynecomastia as well as grade 3 impotence in the androgen deprivation group. So again, further evidence in the pre-dose escalation era for improved survival with the addition of short-term androgen deprivation therapy, and the Harvard study used 6 months. Now we start to get into the era of dose escalation, and EORTC 22991 was a trial of patients with predominantly intermediate risk prostate cancer once again. And these patients were randomized to 74 to 78 gray, so dose escalated radiation, with or without 6 months of androgen deprivation therapy. And the ADT that they gave was a goserelin injection, so LHRH agonist, and they used bicalutamide for 1 month for flare protection. Now in the dose escalated era, that overall survival benefit was actually lost, and they saw no significant improvement in overall survival or distant metastasis-free survival in this study. OS was just around 74 to 80% in both arms, not significantly different. However, they continued to see a benefit in event-free survival. It was 49% with radiation alone versus 68% with androgen deprivation therapy. And they also saw a benefit of 10-year disease-free survival, so 66% with radiation alone versus 76% with androgen deprivation therapy. So almost a 20% improvement in event-free survival and a 10% improvement in disease-free survival. So EORTC 22991 showed improved EFS and DFS with the addition of 6 months of ADT for intermediate risk patients. But now that we're in the dose escalated era, that OS benefit was lost. And again, this trial did not have any subset analysis for favorable versus unfavorable intermediate risk. RTOG 0815 was another trial that was very similar to the EORTC trial that we just mentioned. This was again in the dose escalated era of conventional radiation, so 79.2 gray with or without 6 months of androgen deprivation therapy. And once again in the dose escalated era, just like in the EORTC trial, we see that short-term androgen deprivation improves PSA failure, distant metastasis, prostate cancer-specific mortality, and use of salvage treatments, but there is not an overall survival benefit. So the 5-year overall survival in RTOG 0815 was just around 90% in both arms. But again, significant improvement in PSA failure, distant metastasis, prostate cancer-specific mortality, and use of salvage treatment. And again, with use of short-term androgen deprivation, we see worse acute toxicities. So I think the big takeaway from these studies, number one, is that intermediate risk patients benefit from short-term androgen deprivation. The low-risk patients don't seem to have much of a benefit. They have a very low risk of recurrence to begin with, so it doesn't add a lot of value. The high-risk patients, even with short-term, continue to have a higher risk of recurrence, and so they probably need longer duration of androgen deprivation. So intermediate is probably where short-term androgen deprivation benefits. But based on that Zumsteg secondary analysis of 9408, we saw that the benefit seems to be driven by unfavorable intermediate risk patients, not so much the favorable intermediate. But unfavorable intermediate risk patients, too, are kind of a heterogeneous population, right? And so we really need to be mindful of the absolute risk rather than the relative risk of recurrence, and really utilize androgen deprivation therapy when we believe that it's going to significantly reduce that absolute risk. And these toxicities are not insignificant. Patients do suffer when they're on androgen deprivation therapy, and so we want to spare them that whenever possible. And so in the modern era, we are thinking that personalized tests like Decipher or Artera may help us to guide our decision making and help predict that absolute risk of recurrence so that we can make a clinical judgment as to whether androgen deprivation therapy will really be useful. There's an ongoing phase 3 randomized trial called NRG-GU010 that is investigating exactly this question. Can we use the Decipher genomic risk score to better tailor our treatment for patients? So they are including unfavorable intermediate risk prostate cancer patients that normally would receive the standard of care, which is radiotherapy plus 6 months of androgen deprivation therapy. And they are taking the Decipher genomic risk score and stratifying patients based on that score. So if they have a lower risk of recurrence, so a Decipher score of less than 0.4, they are asking, can we de-escalate therapy for these lower risk patients based on the Decipher score? So patients with a score of less than 0.4 are getting randomized to standard of care, which is radiation plus 6 months of ADT, versus no ADT and radiation alone. The patients that have a higher Decipher score of greater than 0.4, we're asking, do we actually need to escalate treatment for these patients? So those patients are getting randomized to radiation plus 6 months of ADT, which is standard, versus radiation plus 6 months of ADT plus 6 months of darolutamide, which is a newer generation androgen receptor antagonist. And so again, using Decipher score, we know that Decipher score is prognostic, and now we are trying to determine, can it actually be predictive for response to treatment? Can we stratify patients into different treatment arms based on that Decipher risk score? So we are actively enrolling patients on this study, and it'll be really interesting to follow the results. So once again, just to summarize our discussion thus far of short-term androgen deprivation for patients with unfavorable intermediate risk prostate cancer. We first talked about some of these older trials like RTOG 9408 and the Harvard study by D'Amico et al. That actually suggested there was an overall survival benefit to the addition of short-term ADT for 4 to 6 months for patients with intermediate risk prostate cancer. Remember, these trials were done prior to the dose escalation era, so patients were still receiving 70 gray or less with conventionally fractionated radiation, but they showed a significant benefit for survival to the addition of short-term androgen deprivation. A subset analysis of RTOG 9408 actually suggested the greatest benefit for patients with unfavorable intermediate risk and not so much for the favorable intermediate risk patients. In the modern era, where we utilize dose-escalated radiotherapy, we still see that there's a benefit in terms of prostate cancer-specific mortality and event-free survival, but we're no longer seeing an overall survival benefit. And trials from this era are EORTC 22991 as well as RTOG 0815. We now have an ongoing trial, NRG-GU010, where we're actually taking patients with unfavorable intermediate risk prostate cancer and using that Decipher risk score to determine whether we can de-escalate or escalate therapy. So for now, the standard of care is that, we have evidence to support androgen deprivation therapy for 4 to 6 months in patients with intermediate risk prostate cancer, so short-term ADT. Based on those subset analyses, though, we tend to not offer it for patients with favorable intermediate risk, and we tend to offer it for patients with unfavorable intermediate risk prostate cancer. So radiation plus short-term androgen deprivation, 4 to 6 months, is standard for patients with unfavorable intermediate prostate cancer. In terms of what is the appropriate timing for short-term ADT, I don't have a slide on this, but there is a study called the Sandstorm study that showed that when prostate-only radiotherapy is being delivered along with short-term androgen deprivation, a concurrent and adjuvant approach for ADT, so during and after the radiation, offers a benefit in terms of metastasis-free survival. I've also seen in clinic, sometimes when patients have very enlarged prostates, we will sometimes start androgen deprivation therapy around 4 to 6 weeks before we start radiotherapy. And the rationale for this is that with short-term ADT, we can actually shrink the prostate size by somewhere on the order of 20 to 25% at a maximum. And that can help decrease the size of the prostate and make it easier to target for radiation while sparing our normal tissues. Now that we hopefully understand the rationale for using 4 to 6 months short-term ADT for patients with unfavorable intermediate risk prostate cancer, let's move on and talk about the rationale for long-term androgen deprivation therapy, 18 to 24 months, in patients with higher risk disease. RTOG 9202 was a randomized study in the mid-90s, and they took about 1,500 patients with higher risk disease, so clinical T2C to T4. They had some node positive, but mostly node negative patients. The PSA had to be less than 150. And again, this was in a non-dose escalated era of conventional radiotherapy, so 65 to 70 gray of conventionally fractionated radiation. And they were randomized to short-term versus long-term ADT, 4 months versus 28 months. And what they found is that overall in the entire cohort, there was an improved 15-year disease-free survival with long-term androgen deprivation. So 15-year DFS was 10% with short-term versus 16% with long-term ADT. In the entire cohort, the overall survival didn't improve. But for patients with Gleason score of 8 to 10, so these high-risk patients, there actually was an overall survival benefit of somewhere on the order of 5%. They did see worse grade 3 plus late toxicity in the long-term ADT arm, but there was a significant overall survival benefit when they looked at patients with Gleason score 8 to 10. And so the way I remember RTOG 9202, I think 92 of 2, so 2 of 2 arms both received ADT. And so they were comparing short-term versus long-term ADT. And they found that especially for patients with a Gleason score of 8 to 10, so remember that would make you high risk, the long-term ADT was superior even in terms of overall survival for those patients. EORTC 22961 was a non-inferiority trial for patients with predominantly high-risk disease, and these patients were predominantly high risk by virtue of their T stage, so over 70% of patients had T3 tumors. These patients were randomized to 70 gray of radiation with 6 months versus 36 months of ADT. And the results showed that the 5-year prostate cancer-specific mortality was not non-inferior with short-term androgen deprivation therapy. So numerically, they were pretty close, 4.7% 5-year prostate cancer mortality with short-term versus 3.5% with long-term. But the non-inferiority criteria was not met. And so they also found no significant difference in terms of cardiac mortality. And of course, as you would expect, they saw worse side effects of hot flashes, sexual activity, sexual interest with the long-term androgen deprivation therapy. So these were predominantly high-risk patients, and they were high risk by virtue of their T stage. So most patients had T3 tumors. And EORTC 22961 did not find that short-term ADT was non-inferior. So this was not non-inferior to long-term ADT. Now, the prior 2 trials that we just discussed, RTOG 9202 and EORTC 22961, were both prior to the era of dose escalation. What about with dose escalation? Does the benefit of long-term androgen deprivation therapy withstand? So DART 0105 G-Core was a randomized trial of 350 patients with predominantly high risk, some intermediate risk patients, prostate cancer, and they received dose escalated radiotherapy, so 76 to 82 gray, and they were randomized to 4 months versus 28 months of radiotherapy. And so they looked at the results and found that even with dose-escalated radiotherapy, the 5-year biochemical disease-free survival was significantly improved with long-term androgen deprivation therapy. So 90% with long-term versus 81% with short-term ADT. And that was statistically significant. On a subset analysis, they found that the overall survival and distant metastasis benefit were really only seen in the high-risk subgroup. In their 10-year results, so those were their 5-year results. On their 10-year results, they found that they did not maintain a biochemical disease-free survival improvement with long-term ADT, except in the high-risk cohort, they did maintain a biochemical disease-free survival benefit at 10 years. So this is sort of justifying, long-term androgen deprivation, even in the era of dose escalation, and specifically the benefit is for high-risk patients. They did find that with long-term androgen deprivation, the 5-year rate of cardiac events was worse, 18% versus 7%. But, they also found that 10-year biochemical disease-free survival was improved for high-risk patients with long-term androgen deprivation. So the DART study, I think, shows us that dose escalation does not negate the benefit of long-term androgen deprivation. We continue to see a biochemical disease-free survival benefit. And specifically, we see that benefit for high-risk patients. So these are the patients that should be getting long-term androgen deprivation. Now, all these long-term ADT trials have been a little all over the place in terms of what is the duration of long-term androgen deprivation, right? We saw some that were 36 months. We saw some that were 28 months. PCS4 was a trial that looked at patients with high-risk prostate cancer who were receiving 70 gray, and they randomized them to either 36 months or 18 months of androgen deprivation. And all patients received 4 months of neoadjuvant androgen deprivation. What they found when they compared 36 versus 18 months of ADT is that 36 months was not superior to 18 months in terms of overall survival. The overall survival at 10 years was just around 62% in both arms. The 10-year biochemical control significantly improved with 36 months of androgen deprivation, so it went from 69% with 18 months up to 75% with 36 months. But also, they found significantly improved quality of life with 18 months. The testosterone recovery went from 6.6 years with 36 months of androgen deprivation down to 3.6 years for 18 months of androgen deprivation. And with the 18 months of androgen deprivation, 75% of patients had testosterone recovery at 5 years. So we know that the longer you're on androgen deprivation therapy, the longer it takes for that testosterone recovery to happen, even after androgen deprivation therapy is removed. So when we put patients on longer and longer durations, their quality of life is compromised and their chance at testosterone recovery is also compromised. So this is important data because it tells us that 36 months of androgen deprivation is not superior in terms of overall survival compared to 18 months. And although 10-year biochemical control is improved by around 6%, what is the cost of that? The cost is patient quality of life as well as decreased testosterone recovery. So I think this is data that supports, 18 months of androgen deprivation. And a lot of folks will do, kind of balance that out and just do 2 years, so 24 months of androgen deprivation. But I think 36 months is a very long time for patients, and we should try to avoid that if we can. And once again, as we saw in our unfavorable intermediate risk patients, the idea of trying to better tailor our systemic therapy using the Decipher genomic risk score, we are trying to use the same kind of framework to see if we can escalate or de-escalate therapy for patients with high-risk prostate cancer, again, based on that Decipher genomic risk score. So this is a similar trial. It's called NRG-GU009, and it's also called PREDICT-RT. And this trial is now taking patients with high-risk prostate cancer and stratifying them based on their Decipher genomic risk score. You'll notice that the cut point in this trial is higher than what we saw in the unfavorable intermediate risk patients for NRG-GU010. And that trial, the Decipher cut point is 0.4. Here it's 0.85. And my understanding of this is that this has both clinical and practical implications. So clinically, when the Decipher score was validated, there were different risks for distant metastasis for the intermediate risk patients versus the high risk patients. And another factor is that trialists need to try and evenly accrue on both arms of the trial. So these cut points were designed with the Decipher data in mind, as well as the rationale to try and evenly accrue in both arms. So anyway, the NRG GU009 is taking patients with high-risk prostate cancer, and they are dividing patients into a low-risk versus high-risk cohort based on their Decipher score with a cut point of 0.85. Importantly, on this trial, they are not only including patients with a Decipher score greater than 0.85 in their high-risk arm, they're also including patients that are node positive by CT or MRI. So not by PSMA, but by CT or by MRI, patients that are node positive can also qualify for the high-risk arm. Patients in the low-risk arm, so low Decipher score less than 0.85, are being randomized to the standard of care, which is radiation plus 2 years of androgen deprivation, versus radiation with just 1 year of androgen deprivation. So can we de-escalate therapy for patients with a low Decipher score? For patients with a high Decipher score or patients that are node positive by CT or MRI, we are asking, should we treat them with standard of care, radiation plus 2 years of androgen deprivation, or should we add apalutamide in addition to the radiation and 24 months of androgen deprivation? So that's sort of the question in the high-risk arm of the PREDICT-RT study. So here are our major takeaways from the section on long-term androgen deprivation for patients with high-risk disease. So we saw that long-term androgen deprivation improves biochemical disease-free survival in high-risk patients compared to short-term androgen deprivation. And the greatest benefit of long-term ADT with an improved survival benefit is really seen in high-risk patients. And that's based on older trials that were in a pre-dose escalation era. The DART study told us that biochemical disease-free survival benefit to long-term ADT continues to persist in the era of dose-escalated radiotherapy as well. So high-risk patients do benefit from long-term androgen deprivation. Now, the duration that we typically use is 18 to 24 months. I think based on PCS4, we have data for 18 months. I think standardly, a lot of trials use 24 months as a standard. There are some trials that used up to 36 months of androgen deprivation as well, but I think based on that PCS4 study, we see that 36 months really is not superior in terms of overall survival, and patients had significantly worse quality of life as well as testosterone recovery. So I think 18 months to 2 years is considered typically the standard duration of long-term ADT. Now, we did mention the ongoing PREDICT-RT NRG GU009 study that's investigating escalation or de-escalation of therapy based on the Decipher score. But for now, the standard of care for high-risk patients should be radiotherapy plus long-term ADT. The final point that I'll mention is that we have evidence for adding abiraterone and prednisolone for certain high-risk patients as well as node-positive patients based on the STAMPEDE trial. And for those certain high-risk patients in the STAMPEDE trial, they really included patients that had 2 or more of any of these risk factors. So clinical T3 to T4 disease, grade group 4 or 5, and then a PSA greater than 40. So this STAMPEDE data that I'm mentioning is really based on a meta-analysis of 2 trials from the STAMPEDE study. Now, STAMPEDE was kind of a multi-stage, multi-phase study that asked several questions and had several publications, but these specific trials compared ADT alone versus ADT with abiraterone with or without enzalutamide. So this particular analysis included almost 2,000 patients that either were node positive or had 2 or more of the following risk factors: T3 to T4 disease, Gleason score of 8 or higher, and a PSA of 40 or higher, or patients that were relapsing with certain high-risk features. So those are kind of listed there. And the high-risk features were related to their PSA doubling time and how fast their PSA was rising. So these patients were all randomized to either 74 gray of radiation with 3 years of ADT alone, or 3 years of ADT plus 2 years of abiraterone and prednisolone. In the second trial that was included in this meta-analysis, patients additionally received 2 years of enzalutamide. What they found is that distant metastasis-free survival, overall survival, biochemical-free survival, and progression-free survival all improved with the addition of abiraterone, but not with the addition of enzalutamide. So the 6 years distant metastasis-free survival was 82% with abiraterone versus 69% with ADT alone. But they did not see any significant differences for the abiprednisolone versus abipred plus enzalutamide. In terms of toxicities, the patients that received abiraterone did have worse rates of hypertension as well as elevated LFTs. So those are the main toxicities that we think about with adding abiraterone. But based on this STAMPEDE data, I think we have evidence that for certain very high-risk patients, so T3 to T4, Gleason score of 8 or higher, or a PSA of 40 or greater, and they have to have either 2 of those risk factors or be node positive, there is a survival benefit to adding abiraterone and prednisolone for 2 years in addition to long-term ADT. So this was a lot of data as usual, but I think the major takeaways are hopefully summarized on this slide. So for low risk and favorable intermediate risk prostate cancer, when we're treating with radiation, we typically do not add androgen deprivation therapy. If we're treating with radiation for unfavorable intermediate risk prostate cancer, we typically will add short-term ADT for 4 to 6 months. For high-risk patients, we consider longer ADT, so ADT for 18 to 24 months. And then for particular very high-risk patients or node-positive patients, we will often add long-term androgen deprivation plus abiraterone and prednisolone for 2 years. And then ongoing NRG studies are currently investigating whether we can use the Decipher genomic risk score to either escalate or de-escalate therapy based on the risk of recurrence and distant metastasis. Now, there are a few other things that we did not talk about here in this lecture, which we will cover in other upcoming talks. So one of those is androgen deprivation therapy in the post-prostatectomy setting. Remember, we said that when we're treating patients with upfront surgery, we typically aren't just doing surgery and ADT. We typically add ADT to radiation. So if we're doing salvage radiotherapy in the post-prostatectomy setting, we will talk about some of the evidence for adding ADT in that situation in our post-prostatectomy talk. And then, we also use androgen deprivation as systemic therapy, and we will get more into the details of that in our final talk of the prostate cancer series on systemic therapy for metastatic prostate cancer. That brings us to an end of our discussion on systemic treatment for localized prostate cancer. I hope that this was helpful. Again, we're never able to go into every single trial that's been done, but I really tried to highlight some of the most important trials that guide our practice. So hopefully this was helpful to you. Thank you so much for your time and attention.